I did my project over outcomes in athletic training. To really understand the outcomes of athletic training, it's important to understand where they come from, which is ultimately from the disablement models. Disablement models serve as the framework in which the clinical outcomes branch off of. The 4 disablement models that these outcomes branch off of are origin, organ level, person level, and societal level. Since the disablements are so broad, it doesn't really capture the health-related quality of life, but that's where the outcomes come in and provide more specifics and really capture the whole person healthcare and health-related quality of life aspect. I got this picture from an article in the Journal of Athletic Training, and I think it's a really good visual for us to show how the disablement models are connected to the outcomes. As you can see, there's the 4 disablement models that I mentioned in the previous slide, and then branching off from each of them, the different classifications of the outcome measures that come from each of them. There are 2 types of healthcare outcomes, and one is clinician-based outcome and one is patient-rated outcomes. Clinician-based outcomes are really measurements that the clinician makes, including joint range of motion, muscular strength, and joint or limb swelling, and these are known as disease-oriented evidence. These are important but do not necessarily address the health domains that are important to the patient, such as their daily activities and their lives. So that's where patient-rated outcomes come into play, because they focus on values and circumstances being integrated into the clinical decision-making process and is necessary to best serve the patient. I am going to focus primarily on patient-rated outcomes and explaining these to you all because they are very important to incorporate into our clinical practice. They are surveys or questionnaires that we give a patient to complete about his or her health status. They include measurements such as mortality, morbidity, health-related quality of life, function, and satisfactions. These outcomes even produce evidence that is needed for evidence-based and has the strongest ability to change clinical practice if needed. They are categorized in health and health domains of activities and participation. They really highlight the end goals you will need to focus your treatment on and intervention toward achieving. Patient-rated outcomes are characterized by either their applicability or their length. Their applicability branches off into either generic rated outcomes or specific rated outcomes, and length is either single rated outcomes or multi-item rated outcomes. Starting with generic outcome measures, these are global in scope and applicable to a wide range of people, including healthy, injured, or ill populations. These questions are very broad in nature and cover several domains of health. An example of this question would be if you were to ask a patient, in general, how would you rate your health? Generic outcomes allows for global assessment of health status and may provide insight into areas impacted by an event such as injury or illness that is unanticipated. Specific outcome measures are the exact opposite of generic outcome measures. These are a lot narrower in scope and typically relate to a specific body area, disease, or injury. They can also relate to psychological conditions as well. Specific related outcomes are better able to detect small but important changes over time when compared with generic instrument. This creates instrument responsiveness, which is ultimately the ability to capture these small and meaningful changes. Single-item patient-rated outcomes are really quick to score and complete and require no training for use. These are single questions that ask a person to rate how much change he or she experienced in some previous point in time. Some of these are also related to the patient's pain, satisfaction, function, and disability. The biggest drawback to single-item patient-rated outcomes is that you only gain a little information from a single question, and that can limit the amount of information obtained as well as narrowing your focus. These should be considered when implementing a routine assessment of a patient-rated outcome in clinical practice because they are quick and easy to use and provide guidance on aspects of health important to the patients. Multi-item patient-rated outcomes are pretty much the exact opposite of single-item patient-rated outcomes. These ask the patient several questions about various aspects of their life and provide a lot more comprehensive assessment of what you're interested in knowing about the patient. It gathers information on more than one disablement domain and it can even construct a health-related quality of life. It provides a lot better understanding of the impact of injury or illness on the patient's life. Obviously, with multi-item patient-rated outcomes, there's a lot more questions, so that means you need to plan ahead because there's a lot more time needed to complete these. But the value of these instruments completely outweigh the time it takes to put the measure into practice. The next couple of slides are over health-related quality of life, which is a huge part of outcomes in athletic training. Health-related quality of life, by definition, is a multidimensional construct that includes physical, psychological, social, spiritual, and economic domains of health. It is an individual's satisfaction with life and his or her general feeling of personal well-being. This should ultimately be the standard endpoint in clinical research. Since it is a combination of interacting health-related dimensions and personal beliefs and experiences of the patient, it truly makes it a patient-centered construct. It can also create patient-oriented evidence that matters, which is useful for us when we are justifying what treatments to do for our patients, determining treatment effectiveness, and changing clinical practice. I got this picture from an article in the Journal of Sport Rehabilitation because I think it provides a good visual for us all to understand exactly what the health-related quality of life is. As you can see, each of the domains that I mentioned are in this picture and they all show that they overlap and are all multidimensional, which increases the conceptual complexity of the health-related quality of life. For example, social domain could include the patient's family, friendships, and recreational activities. And along with psychological domain, that includes emotional behaviors, happiness, stress, or depression. So this picture just is a visual of what the health-related quality of life really is and to show its multidimensional aspects that are involved within it. We can measure health-related quality of life through either generic or specific measures within the patient-related outcomes. Generic are more comprehensive in capturing the health-related quality of life than specific because there's emphasis on the global health in comparison to something that's specific. Once you select a patient-related outcome instrument, it can be administered at various points in time along the patient's recovery. This is referred to as serial administration, which allows you to capture the peaks and valleys in the health-related quality of life. It is also important to note that athletes report a higher health-related quality of life than the general population because that is who we typically work with on a daily basis. Now that we went over the different kinds of outcome measurements and specifics, I provided you with a list and some examples of some common generic, specific, and single-item pro outcome measurements on the outline that you guys can look over and feel free to look into more depth on each of the common generic, specific, and single-item outcome measures that are used in our clinical practice. So now that we've gone into great detail of what outcomes actually are and where they originate from, we can move on to how to incorporate them into our practice, and these are 6 important things to keep in mind when deciding what outcome to use. The outcome that you choose needs to have good face validity, content validity, construct validity, and criterion validity. By face validity, you need to determine whether the instrument appears to measure what it is intended to. By content validity, it refers to how well the constructs of interest are comprehensively sampled by the questions included in the instrument. By construct validity, it measures of what the patient tells us. For example, It assesses the observable constructs such as pain, anxiety, or fear of re-injury. By criterion validity, it means that it shows that the shorter versions of the questionnaires of the outcomes are just as reliable as the long ones. So for example, SF36 only has 36 questions, but SF12 has 12, but 12 is just as reliable as 36. The outcomes also need to have good responsiveness, and by this it means that the patient-related outcome speaks to the ability of the instrument to capture or measure meaningful change over time. This can be shown by minimally clinical important difference, also known as MCID. It is the smallest amount of change that the patient perceives as beneficial. So when the patient retakes the outcomes, we want to see a score improve by 11.5 to make sure the patient is perceiving beneficial change. If the score is not improving by 11.5, then we know that we need to change our treatment or intervention that we are doing with our patients. Besides just having good validity and responsiveness, the outcomes also need to have good reliability. Two characteristics that go along with reliability are reproducibility and internal consistency. These refer to the ability of an instrument to produce the same score when a patient completes the instrument on more than one occasion, assuming that there is no change in health status. It suggests that a period of time between 2 and 14 days is appropriate when evaluating a retest reliability for patient-related outcome. You also need to make sure the outcome is appropriate, acceptable, and feasible. By making sure the instrument is appropriate for its intended use, making sure that it focuses on the patient friendliness and the patient agrees to do it without any anxiety, and consider how feasible it will be for you to administer the instrument to your patient. It is important to use patient-related outcomes for a lot of purposes. It really enhances our clinical decisions, and we need to make sure when selecting that they are valid, responsive, and reliable for our patient in need. When choosing the right patient-related outcome, ask yourself these 3 questions. Is the instrument measuring what you intend it to measure? Is it truly measuring what it is designed to measure? And is it useful for its intended purpose? I hope you enjoyed this presentation on outcomes, and I look forward to reading the discussion board comments.